Welcome, everyone, to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the University of New Mexico's Division of Forensic Behavioral Sciences in our Department of Psychiatry and Behavioral Sciences, along with support of the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology's Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, you can enter those in the Q&A box. Feel free to enter those anytime you feel comfortable, but do know we hold them to the end, and oftentimes it's not possible for us to get through all of them. For those of you that are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly. If you are pursuing APA continuing education credits, you will keep your eye on the chat box as well, but near the end of the presentation, where there'll be a link for a survey that you complete. Make sure that you bookmark, open up, otherwise save that link before the webinar closes so you have access to it. And make sure that you save a copy of the certificate you get after completing the survey. We don't have certificates after the fact. If you missed last week's talk in the series, Dr. Dana Foreman's discussion of practical considerations about artificial intelligence's use in forensic psychology practice is now available on our YouTube channel. The recording for this week's talk will also be available on our YouTube channel sometime later this week, and a version of PowerPoint slides for those that have registered for the series will be available later this week as well. As a heads up, next week we have Dr. Ira Packer, who will be discussing the need for hospitalization assessments in competency examinations. But circling back to this week, I'm excited to introduce you to today's speakers who'll be discussing trauma-informed supervision of forensic trainees. Today we have Dr. Julie Goldenson and Dr. Terry Kukor. I'm assuming you have their bios, so I will be doing abbreviated introductions here. Dr. Goldenson is a psychologist and assistant professor at University of Toronto, having evaluated the impact of alleged trauma-related harms, authoring numerous publications advancing trauma-informed practices in forensic mental health, particularly in the assessment and supervision of trainees. She's provided international training on these topics, and in 2021 received the Strasburger Award from the Program of Psychiatry and Law, affiliated with Massachusetts Mental Health Center, Harvard Medical School. Dr. Terry Kukor is a board-certified forensic psychologist now in private practice, previously at NetCare Forensic Center in Ohio. He's currently associate faculty at the Ohio State University. He's past co-chair of the American Academy of Forensic Psychology CE workshops and was recognized with the Distinguished Contributions to Forensic Psychology Award by the AAFP in 2019. So, Dr. Goldenson, Dr. Kukor, Julie and Terry, on behalf of the University of New Mexico, thank you so much again for joining our series. Thank you for the work that you've been doing in this area, and we're very excited to hear what you have to say. I'll go ahead and toss it over to you.
Thanks, Anthony. And we're going to go over some of these initial slides quickly. Many of you have attended this excellent series for a long time. This is the information you need about CE credits. We're not going to go over that in any detail. Disclosures. The key things you need to know is that neither Julie nor I have any financial arrangements related to the content of what we're going to be presenting today. And certainly it should not go without saying that we are speaking for ourselves rather than the University of New Mexico. If one of us says something today that you find objectionable, you should certainly contact Julie with all complaints. We have several objectives today, and they're fairly concrete. We want to begin by describing supervisory obligations that we believe are specific to the forensic work that many of us do. We want to identify signs of secondary traumatic stress in a practical way so that all of you can recognize it when you see it. And then we want to describe very specific concrete ways in which you can inform or incorporate, rather, a trauma-informed approach into any forensic supervision work that you do. The content that we're going to be covering today is largely drawn from an article that Julie and I co-authored along with Doctors Patricia Carrig and John Taylor. If anybody wants a copy of this article, we're happy to provide it for you. Each of our email addresses is on the title slide of this PowerPoint. Let's begin with clinical supervision, and we want to make a couple comments on that before we do a deep dive into forensic supervision. There's plenty that's been written about clinical supervision, much less about forensic supervision. But we want to begin by looking at goals and responsibilities. Bernard and Goodyear did a marvelous job describing particularly the goals. And in a nutshell, we're responsible for enhancing a trainee's professional functioning. This is the knowledge and skill component of what happens in supervision. Second, we're responsible for standing behind the quality of the services that trainees provide. And at least in my jurisdiction, I have to add trainees to my professional license, meaning I'm responsible for what they do or do not do that they should have done or should not have done. And then lastly, we're gatekeepers for ensuring compliance with ethical standards. Many students are savvy about what those standards are, but perhaps not so much about what it means in a practical sense to apply those to clinical work being done. On the other side, there are key responsibilities. Now, there are many, many different models of clinical supervision that you will find in the literature: developmental, process, competency, and skill-based models. All of them share some common responsibilities, and let me note those. The first is the administrative support that we provide. This is often referred to as part of the scaffolding that we build up around a student to help them function in the environment in which they are functioning. Um, we are responsible for a teaching component, and this is the vehicle by which knowledge and skill tend to be imparted. That might be live feedback, might be feedback on reports, it might be feedback on treatment services that are provided. And then lastly, this is an interesting one, and it dovetails nicely into what our focus is today, providing support for managing job-related challenges. And as we will see, we are going to make a case that forensic supervision has some rather unique job-related challenges that should be kept top of mind. And here they are. Number one, there are challenges that a trainee often might not have thought about or been prepared for, not the least of which might be safety concerns. For people that are working in a forensic psychiatric hospital or doing jail-based evaluations, it can be a little unnerving to see the presence of law enforcement or the lack of presence of law enforcement that when we are doing evaluations. There are ethical considerations that are important here, and helping supervisees navigate um, some of these contours when we are maybe have a different purpose in some of these environments than do correctional staff, for example. And then third are the adversarial dynamics. Most of us that have been in this field for a long time, very accustomed to talking to judges and attorneys. And often we find that the reports that we write, one side might be happy or happier with a report than the other side. That can be new for a trainee and can be very difficult for somebody that has historically focused on getting it right clinically, and now they find that they've got some downstream customers that may not be so happy with their work. Let's pause here for a moment and recognize that that all these things add up to pretty significant emotional demands and on forensic trainees, and these have been largely underexplored in the literature. And that's part of why we wanted to present on this topic today. Most of us tend to focus on the wide range of knowledge and skill that somebody needs to have in order to do forensic work. And my personal take on this is that it would be a mistake to assume for me that I've always gotten this right. I haven't. I have learned the hard way, both after writing the article and in doing this presentation, preparing it, that I've been humbled by the many times that I haven't done some of the very things that I'm going to be recommending. I believe that's all part of striving. And if anything, it should inspire us to do better. I think Maya Angelou said something like, do the best you can until you know better and then do better. And that's exactly what my experience has been like, focusing on some of this underexplored area.
Thanks, Jerry. Before discussing the emotional toll of forensic work, I just wanted to take a quick detour and name some of the emotional challenges that many of us face just by virtue of being a human. And I doubt this is news to any of us here. Most of us are familiar with the Adverse Childhood Experiences study by Vincent Felitti and colleagues. And the original study, which has been widely replicated, found that ACEs were prevalent, they often co-occurred, and had a pretty negative impact in the sample of middle-aged, middle-class Americans. So the implication is that regardless of our background, our education, our SES, some of us might be negatively impacted by childhood adversity. Also, statistically in our lifetime, we'll likely be exposed to at least one and more likely to potentially traumatic events. This is not to say that we're all going to go on to develop PTSD, but trauma exposure is pretty common and we're certainly not immune. And of course, forensic psychology trainees are also no exception to such exposure. This is a large-scale study by Victor and colleagues, aptly entitled Only Human: Mental Health Difficulties Among Clinical Counseling and School Psychology Faculty and Trainees. And they reported that over 80% of their 1,700 respondents endorsed a lifetime history of mental health difficulties, and nearly half reported a diagnosed mental health related disorder. So this really says something about the potential vulnerability of our trainees and potentially ourselves as well. It probably goes without saying, and Terry alluded to this, forensic work itself can expose professionals and trainees alike to graphic and potentially traumatizing materials that we often can't talk about at the dinner table. And sometimes this exposure might be in the form of graphic video evidence, might be victim impact statements or synopses of violent or sexual offenses. Sometimes the exposure may be from learning about an accused person's history of victimizing others. And we know that sort of victims and offenders is a bit of a false dichotomy, as often a lot of people who have committed offenses have a pretty robust victimization history as well. Forensic treatment might pose some distinct challenges in that it often requires us to have some degree of compassion and empathy, and this can really amplify emotional resonance with potentially traumatic material. And thinking about the adverse consequences of working in professions where there's significant exposure to potentially traumatizing material, there are a number of terms that are used inconsistently and sometimes interchangeably. I'm sure you've heard them used. These include secondary traumatic stress, vicarious trauma, compassion fatigue, and burnout. And in the interest of time, I'm not going to try to make distinctions between these terms, but we do so in our recently published paper, and Pirelli and colleagues in 2020 also offer some fabulous distinctions as well. It's interesting to note, I'm going to focus now on secondary traumatic stress, and it's interesting to note that this concept came to be recognized only as recently as the DSM-5, so in 2013. When the revised definition of trauma for the first time included repeated or extreme exposure to the aversive details of another person's traumatic experience. It's also worth noting that this definition includes an explicit example of those who encounter repeated exposure to these details in the context of their work. So if we bear this in mind, it certainly makes sense to think of STS as a professional competency for those whose work involves interacting with trauma-exposed clients or engaging in trauma-related material, as is the case for many forensic professionals.
Thank you, Julie. Let's turn next to how might we know it when we see it in terms of secondary traumatic stress. And what we offer up on this slide are some indications across several distinct but related domains of psychological indicators, physical symptoms, behavioral changes, and even a spiritual impact. Let's be clear that we are not making the assumption that just as everybody that is exposed to trauma does not develop PTSD, nor does everyone that's exposed to traumatic stimuli on a forensic case, for example, develop STS or secondary traumatic stress. If we could take a poll, I would suspect that many of you would acknowledge having thought, gee, I wish I hadn't seen that. I wish I hadn't heard that. The things that stick with us in a negative way. And there are sometimes disturbing images regarding the traumatic experiences people have endured. But for those that do develop secondary traumatic stress, we might begin by looking first in the psychological domain, where we might predictably expect there to be some cognitive intrusions. So the unwanted memories, particularly thinking about things that you've seen or heard at a time when it's not particularly adaptive to do so. There might be avoidance, there might be negative alterations in thinking and mood, or even an arousal and reactivity. Sounds a lot like a trauma response, and that's because it is a trauma response. Physically, you might see manifestations such as fatigue or sleep disturbances, or even an increase of somatic complaints, headaches, stomach aches, where perhaps in the past they haven't been part of the picture. You might see individuals exhibiting behavioral changes, whereas they may have started their training year or experience with you with a busy social life. Perhaps there's less of that. Perhaps they are showing up less frequently at sponsored social events. You might even see an increase in substance use in a way that becomes more obvious. And at the broadest level, there may be a spiritual impact. And we're not saying here that everybody has or should have a spiritual component to their life. It's a very deeply personal choice and investment people make. Think about it as a change in worldview, so that if somebody begins to see the world as inherently dangerous or bad or provocative, and that safety above all has to be maintained no matter the cost, you may be looking at somebody that has experienced a change in their world view. Now, there are risk factors. Just as there are risk factors for suicide and violence, there are risk factors for developing secondary traumatic stress. First, there's the issue of pre-existing emotional vulnerability. And as you might expect, individuals that have a history of trauma themselves might be more susceptible to SDS. And this should raise a question for all of you that are supervisors. How much do you know about the trauma history of a supervisee? We're certainly not recommending that you do a detailed trauma inventory here, but yet this is something that you might want to think about. What kinds of questions are not over the line to ask of a trainee in terms of perhaps more broadly things about them, about experiences that they may have had in the past that might usher in difficulties dealing with a current case. That might be one way to do that. Trauma exposure frequency, again, as you might expect, that frequent exposure, multiple traumatic events in one's past increases the risk of STS. Professional isolation is a really important one, and you need to bear in mind, particularly if we're talking about psychiatric residents, psychological postdocs, or interns, they are there with you for a limited period of time, and many of them have moved across the country. They're in a brand new city away from sources, ready access to sources of support. They may be more isolated than usual. That can be a risk factor. And then lastly, the work environment itself. They may be carrying a higher caseload than they have typically experienced. For the first time in their careers, if they're writing reports, they may be exposed to the additional pressure of expected deadlines for reports. All of these things combine to establish a pretty deep profile of risk for developing STS. Next, we want to talk about developmental considerations. Trainees often bring something unique to the table in terms of a vulnerability, and we might think about it in terms of a lack of confidence. Some might openly talk about imposter syndrome and lack of really positive self-regard despite all their successes when they are now wanting to be successful in the forensic work that they are training to do. We know that age and established regimen of coping capacities are protective, so that older individuals that may have more experience, you can think of it as more calluses, perhaps, that serve a protective function that our younger colleagues or less experienced colleagues may not have. And then lastly, the impact of race. Individuals from communities that are marginalized may experience greater burnout. And that's one of those words that you'll see in the literature. And again, we're not drawing a distinction between burnout and STS here. We're lumping it all together. But individuals that have perhaps been on the wrong side of microaggressions have been found to be more vulnerable to STS. Let's talk a bit about barriers to disclosing emotional challenges. Probably many of you could generate every single item on this list based on your own personal experience of asking or not asking for help, or your experience working with trainees. As you look at the list of things here, I want you to ask yourselves, has a supervisee ever disclosed to you an emotional challenge? And depending upon what your answer is to that, I encourage you to reflect on the reasons why that may have happened or it may not have happened. And ask yourself as well, have I ever asked what it was like to look at some gruesome items in discovery, for example? One of the barriers then that is commonly been found is just the stigma that becomes associated with acknowledging that something was really, really difficult. Um, Many of us were trained in a training culture in which the often tacit message was, look, this is the deep end of the pool. You got to be tough. You got to be able to handle this. Whether it's shown on the outside or not, there's something different maybe going on inside at all those different levels that we just talked about. Personally, I think I have dealt with a lot of that with kind of a dark humor that I honestly kind of like, and I think to a certain extent is adaptive, but we can all do better than that if we are really trying to encourage supervisees to disclose when they are really struggling with something that's very difficult. Now, we have some ethical obligations that we I think are important to mention. Julie and I are both psychologists, so we picked standard 2.06 from the Ethical Principles of Psychologists and Code of Conduct. They basically boil down to this. If our professional competencies or objectivity are threatened by some work, we should think twice about starting that work. And if we are underway in a case and these same things come up, we should really consider limiting or stopping our involvement, for example, in a case. It's a wonderful opportunity for consultation. And I think the value of having a trusted other to talk to um, can't be overemphasized. The point I want to leave you with on this slide is, and I'm going to say this more than once today, have the conversation, not just once, but have it top of mind as you go through cases and in your supervision with trainees. Have that conversation about what something was like to hear, what it was like to listen to, what it was like to see.
Thanks, Terry. So the emotional harms from STS deserve attention in their own right, as trainees and even seasoned professionals deserve to be working in systems that prize their well-being. But it's also important to recognize, and I think Terry alluded to this, that STS can have professional consequences, and we're certainly engaged in high stakes work. Both in the capacity as a treater or an evaluator, our emotional reactions can lead us, sometimes unwittingly, to act unskillfully with people being seen in forensic contexts, which can lead to things like breakdown in rapport with forensic clientele, and that can adversely impact our ability to engage in a meaningful way. We also might avoid asking questions about topics that are evocative or upsetting for us, and that can lead us to miss some pretty vital information that's necessary both for accurate assessment and good quality treatment. Emotional reactions can also probably lead us to have some bias when formulating findings in high stakes evaluations, including potentially increasing our risk judgments. And negative emotional reactions to patients' past actions can impact a forensic clinician's capacity to cultivate sufficient compassion, which can certainly hinder effective treatment. Treatment. So I wanted to talk about my personal investment in this topic. It has some special meaning to me, given my own early career experiences as a trainee in forensic contexts. And Terry did a lovely job of foreshadowing some personal and professional risk factors that could increase the risk of STS. So as a forensic trainee, I had some vulnerability. Maybe I was a bit of a poster child, unfortunately. I'd endured a recent traumatic death of a close family member, so my own traumatic loss was definitely front and center for me when I did a forensic residency. I also moved away from a pretty close network of friends to attend the residency and relocated from a lovely sunny climate to a cold cold and gray climate, which led to some disengagement from nature and my usual coping strategies, and led me to be a bit housebound and face down in a bag of chips. So it was kind of a fattening time. Um, there were also some professional risk factors. I spent many of my days in a windowless office, and there weren't many other trainees. My supervisors were lovely and very competent, but there wasn't a lot of training at that time on trauma-informed care, on secondary traumatic stress, and the bulk of my supervision really centered around report writing, which is a skill I am still very grateful for. In terms of the institutional culture at that time, there wasn't a huge amount of interest in employee wellness. And in fact, there were a number of incidences in which employees had been assaulted by justice-involved folks. So there was some public concern about safety that was actually in the media. And there was definitely one case that did me in. I was conducting therapy with someone who had killed a family member in a state of psychosis. I recall finding the therapy really heartbreaking. And at that time, there wasn't really anyone there to supervise this kind of therapeutic work in a way that it needed to be supervised. So I recall feeling pretty alone and pretty over my head. When I look back now, it's hard to know whether I met full criteria for STS, and it doesn't really matter. I know we're talking about STS, but even sort of subclinical manifestations and emotional distress can be both taxing and create some impairment in functioning. What I recall from that time is feeling that the world was a pretty dangerous place. I recall feeling pretty personally and professionally demoralized and probably a bit low. I was offered a permanent position at this place, but decided I needed to leave. Maybe that was a flight response, and I left not only the setting but the province. And I also moved out of forensic practice for a couple of years, but found my way back in outpatient context, largely doing assessments. Um, I think my story ends really well. My shift in worldview, my vigilance, my low mood eventually abated, and I really love my career. But I do wonder how things could have been a bit different if I'd been working in the context of a more trauma-informed organization and was more equipped, that was more equipped to provide more meaningful support to trainees. So that brings us now to the crux of this talk. As part of caring for our trainees, it would probably make sense to institute trauma-informed supervision. And I wanted to talk about what this might look like beyond being a bit of a buzzword. I don't think we really need to reinvent the wheel. Trauma-informed principles have already been applied to supervision in clinical contexts, and we can tailor this to forensic contexts as well. And really, what a trauma-informed model to supervision involves is the nexus of trauma-related knowledge and core clinical supervision skills. So that means that trauma-informed supervisors are familiar with the biopsychosocial legacy of trauma on survivors, and that they also understand the indirect impact of trauma on service providers and trainees. And Berger and Quiros in 2014 note that a trauma-informed approach to clinical supervision requires a couple of things, including transferring knowledge through teaching, training, and overseeing clinical judgment. So that's that educational function that Terry talked about earlier in the presentation. And it also involves assessing supervisees' vulnerabilities and resilience relative to the trauma-related content that they experience, and helping them address job-related stress and challenges and exercise some self-care. And that's that supportive function that Terry talked about. It also involves the delegation of a balanced trauma-related caseload and guiding the implementation of the agency's trauma policy. And that's an administrative function. And Terry will talk about that in a moment, that, we don't exist in a vacuum, and there's some cultural aspects that need to be addressed. So now I wanted to talk about how we might apply a trauma-informed approach specifically to forensic settings. I think self-evidently, part of being trauma informed is being informed about trauma. And forensic supervisors can only really teach what they know, but research seems to suggest that training on trauma, and particularly complex trauma, is still often missing in graduate level psychology programs, at least in North America. So at a foundational level, just as forensic supervisors require specialized training and competence on a variety of psycholegal topics, they also ideally have or seek out some training on assessing and treating trauma among forensic populations, core principles of trauma-informed service delivery, and how to mitigate the risks of STS both in themselves and in trainees. We can also likely only authentically model what we actually practice as supervisors. And it's quite likely that many supervisors, particularly those of my vintage or older, like Terry's vintage, sorry, Terry, have not been supported in managing the emotional toll of forensic work. So we need to be aware of and attend to our own emotional vulnerabilities and our reactions. And ideally, supervisors have their own resources to engage in consultation and some sort of reflective practice, even if that's, casual peer consultation, which Terry and I do together and is really helpful. And we can authentically encourage trainees to do the same over the course of their careers, whether this is formal or informal peer consult, or sometimes personal therapy. And I do notice that forensic folks seem to sometimes, they don't poo-poo therapy, but they don't talk about it a lot, which is sort of ironic given, we're all trained in mental health and, talk about how much we value therapy. There's a good article by Davies and Jones, and they write compellingly about organizational consultancy and how this sort of consultation can be built into organizations. Part of what we did in our paper is consider how the 5 original trauma-informed principles proposed by Harris and Fallett in 2001, adopted by almost everywhere, including fostering safety, fostering choice, trust, collaboration, and empowerment, could map on to forensic supervision. And I'll start with safety. If we consider Maslow's hierarchy here for a second, if we don't feel safe, we probably can't do great work. And certainly, as Terry mentioned, and I've talked about, concerns about basic physical safety can be amplified in forensic and correctional settings, and there might be legitimate safety issues. So these concerns should probably be carefully managed for our trainees and ourselves. If we graduate and move up Maslow's rung a bit, ideally supervisors foster the needed relational safety for trainees to be able to express personal reactions to forensic work without fear of reprisal. As part of enhancing emotional safety, we should be aware of signs and symptoms of STS and monitor for these, and I'll talk about this a little more in a moment. Another thing is that we need to consider power differentials. Supervisory relationships inherently grant some structural power to supervisors. We assign tasks, evaluate performance, shape professional growth. We also bring distinct socio-demographic characteristics which impact interpersonal dynamics, like differences in age, race, class, and gender. Certainly, supervisees from marginalized groups may feel especially vulnerable in supervision with supervisors who hold more privileged identities. Berger and Quiros describe trauma-informed supervisors to, as they put it, flatten the power pyramid by inviting supervisees to have explicit conversations about aspects of identity and how these may play out in both professional roles and, when appropriate, in supervision as well. Part of flattening the so-called power pyramid is giving supervisees some choice. It sometimes could be in the best interest of both trainees and the forensic clientele whom they might be assessing or treating to be able to exercise some choice in terms of taking on a particular forensic case that might pose too great an emotional challenge and significantly compromise their effectiveness. If we're being realistic, though, it's not always possible to predict which cases are going to elicit a strong emotional reaction. And in settings with long wait lists and heavy caseloads, trainees don't always have the luxury of picking the cases that they take on. So ideally, in those cases, supervisors are available to provide impromptu support in cases where, it's clear that a trainee is finding it pretty emotionally challenging. Of course, we have to acknowledge that forensic practice is likely to be rife with cases that pack an emotional punch. But when trainees can learn to navigate emotionally challenging cases with the aid of supervision, this has the potential to build some resilience and a sense of self-mastery that they can carry forward into their careers. As threatened, I wanted to discuss a bit more explicitly ways of assessing our capacity to identify and mitigate secondary traumatic stress in our supervisees and in our supervision. You'll see a link here to the STS Core Competencies and Trauma-Informed Supervision Self-Rating Tool, which is certainly a mouthful. It was designed to help supervisors evaluate their proficiency in supporting trauma-informed practices. And you'll see here that it encompasses key areas such as understanding trauma's impact, fostering a safe supervisory environment, and recognizing signs of secondary traumatic stress in both supervisors and supervisees. Some of the core skills that are assessed include, but are not limited to, being able to detect the signs and symptoms of STS and monitor for them in their supervisees, and Terry discussed some of these signs and symptoms, creating a safe environment for supervisees to reflect on these experiences, and the ability to assist supervisees to re-regulate after they've had difficult encounters. And this probably requires us to know something about trauma and arousal and regulation. It also involves helping supervisees to use a trauma-informed lens to understand their evaluees or forensic clients and our own reactions to these individuals. And this is an important one, I think. It also requires us to be able to recognize the difference between changes in worldview and perspective, which Terry talked about. Some of these changes might be normative as we grow into forensic work, but we want to distinguish those from changes that might reflect trauma-related changes with cognition and mood. Patricia Carrig, who you probably have heard of, was a co-author on her paper and pioneered something called the Resilience for Trauma-Informed Professionals, or RTIP. And this model is intended to be applicable across a broad spectrum of professional roles that involve exposure to secondary traumatic stress, including the justice system. I can't do justice to her work, and I need to give her credit for a couple of these slides, but she provides a really excellent workshop and professional training on this topic, and I'm not being paid to promote her here. I'll summarize her model briefly. Her model introduces skills that can be used at each stage of a supervisee's encounter with secondary trauma. The first one is prevention, and I think this is important. And this includes preventing preventable exposures. It may involve considering what material our supervisees really need to see. I know I've been exposed to some pretty graphic evidence that really did very little to help me understand a case. Second are helping supervisees develop skills in anticipation of exposures and to enhance their self-efficacy in working with individuals who have experienced trauma and have trauma-related symptoms. And studies do show that self-efficacy is a real protective factor against secondary traumatic stress. Third are skills trainees can use in the moment when they encounter secondary traumatic material, including knowing how to respond helpfully to trauma disclosures, being ready to respond when someone is becoming pretty activated or triggered, and knowing how to ground ourselves and recover when we feel a bit dysregulated or shaken up by one of these encounters. And finally, there's some skills to use in the aftermath to help trainees monitor their own level of STS and help kind of downregulate and restore their equilibrium.
Julie, did we skip one?
Mm. Oh, shoot. We sure did. Here
There
we
it
are.
is.
Sorry, Terry.
That's okay. Thank you. We want to spend a moment recognizing that many of us work in an organizational setting, and organizations have cultures. One of the most difficult things when you're new to an organization is understanding cultural norms. Things like, is it okay if I stay late? How are birthdays celebrated? Am I allowed to say anything personal about myself? And on and on and on. My point being that we want to locate our responsibilities towards supervisees in terms of the organizations in which we work and how safety issues are handled either in our professional practices or in policy and procedures. We want to be clear that we've got not just a stake, but Jewel and I believe a responsibility to exert a positive influence on the evolution of that culture towards something that better enables supervisees to really grow into confident young professionals. Um, One of the key points here is that if we think about STS being an occupational hazard rather than a sign of weakness, and if that's being talked about, it's by a supervisee, it's an opportunity to improve the culture in a very practical way. That may take a long period of time, but we want to highlight the importance of the responsibility that all of us have towards helping make that happen. And then lastly, there are a couple take-home messages. Hopefully, we have tried to be constructive and positive as we've gone over these topics to leave you with a sense of some concrete things that can and should be done to improve the experience of supervisees from a trauma-informed perspective. You'll see that these are, I think, the takeaways from the literature that we have reviewed for you today. The two key points that I want to make, I think, that reside either just underneath or just on top of these takeaways are twofold. Number one, help students build a sense of mastery. If dealing with STS and the traumatic implications of the work we do is a skill, and Julie and I believe that it is, that's something that has to be practiced and talked about. So again, have those conversations with people. And then lastly, do not overlook the enormously powerful impact of modeling. I learned this the first time after a very difficult interview. The first thing I said to a student was, whew, that was a lot. Uh, Communicating, hey, it's okay to that we name this. It's okay that we talk about it. I think that's good modeling. And to the extent that you can make that an okay thing to do, that will be an invaluable lesson that you can impart to your supervisees as well.
Great. So yeah, we welcome thoughts, personal experiences that you wish to share, any sort of comments. We've included the references, you'll have those. And I think I'll stop sharing just so we can get to any questions or comments that came about as a result of our presentation. So here we are.
Well, thank you so much for that, Julie and Terry. And I also appreciate the timing here where we're, relatively early, at least in some postdoctoral fellowships, thinking about these kinds of modeling behaviors as we're increasingly in these phases of our trainees directly observing the services that we do and the way that we go about our day-to-day lives, thinking about these examples about normalizing the processes, the discussion, thoughts, the experiences that we have. So thank you so much for placing that through this narrative as well. We do have a number of questions here so far. If you have any other questions for Drs. Goldenson and Dr. Kukor, feel free to enter them into the Q&A box at any point. Shortly, in the chat box will be the link for the APA Continuing Education Survey. I'll confirm when I do see that posted as well here. So one person, I'll go ahead and forward thinking here, somebody with the note of their faculty in a doctoral clinical psych program that has students often entering forensic practicum. They said, besides sharing this information here, and thank you, so helpful, are there specific resources like books or articles that you think would be helpful?
Yeah, there's actually a great book by Knight that's on trauma-informed supervision. Certainly, we can share our article. As I said, Patricia Carrig is fantastic. She actually does a full workshop related to this material, which really sort of fleshes it out. And I think that would be an excellent resource as well.
Wonderful. Yeah.
What I would add to that is just become familiar with the likely signs of STS. And again, make it a habit to get to know that side of what that work is like for your supervisees and make it a regular topic of supervision that you have discussions about how difficult some of these things are.
Wonderful. Just got a comment, somebody, thanking you, saying, so glad this topic is entering the overall conversation. When they were in training years ago, the only idea proposed for helping with one's own reactions was to make sure we were in therapy. And somebody asked, what may be an example of a step-by-step plan for a supervisee who has undergone a traumatic event due to work at your agency?
Well, I think first of all, it's important that role boundaries be maintained. We are certainly not advocating that a supervisee ever slip into the role of a psychotherapist for the person they are supervising. Our task is really to help supervisees identify, cope with, and more effectively manage responses that they have to traumatic stimuli in the work that they're doing. It's not to resolve the what may be unprocessed emotions they might have from past trauma. Rather, it's to, and there's a way to talk about employee assistance programs or treatment if that's necessary. But I think our part is to focus on what can what steps might be taken so that these things are not getting in the way of somebody being objective and competent. And that all depends on how strong the reaction was. Sometimes it's better to fail to start than start and fail. And that may mean pulling a student off a case. On the other hand, I really want to emphasize this, that if our focus is on building mastery, that's on teaching in a practical way, including self-disclosure about how you learned to cope with and carry some of the most painful stories anybody on earth is going to hear in your own practice. That's about building mastery. I wish we had another hour to say more about that, but that's my 2 cents worth on it.
Yeah. I think each case is different. I want to reiterate that I teach a supervision course and there really is some complexity. Terry said, we need to just ask. And yet at the same time, we're gatekeepers, we're evaluators. It is a really tricky sort of position that we're in. And I agree that some things probably need to get farmed out to some personal therapy, but we can talk about cases that feel manageable, and maybe that's the choice and empowerment piece. And if something feels too overwhelming, maybe we skip that particular case and we have candid conversations about that, and figuring out, if things are going south, whether it's appropriate for someone to opt out if it's causing either too much psychological distress or compromising someone's competence to work on a particular case.
And what recommendations do you have or challenges have you found in approaching that conversation that might result in transferring a case? Say, particularly if there's a time constraint here where we need to make a decision soon of who's going to see this person. Any recommendations or considerations when you might be under a constraint to have those conversations?
Well, in the heat of the moment is one of the hardest times in life to make important decisions. So the first bit of advice is anticipate this and have this conversation with your training staff in terms of how can we better move in this direction? How do we introduce the need to have conversation with supervisees about their emotional responses, their reactivity, whatever you want to call it, to potentially provocative material. If that conversation is started sooner, then it becomes part of the culture, and then it doesn't stand out as different from the norm, particularly if you start having those conversations early. And again, the self-disclosure part is really important there, that even if you have professional calluses built up, I think pausing for a moment and talking about how difficult it was to continue listening as somebody was describing something horrific can do a world of good.
Wonderful. This question came early on in the presentation, so it might touch on some of the things you addressed later on. Somebody asked if you would suggest relevant stages of STS for forensic and other related peers involved in a case of medical error resulting in death or serious injury to someone.
I'm not sure I understand the question. Terry, do you?
I was hoping you were going to tackle this one. I'm not sure that I do either. Um, but maybe if I don't know that we know enough to have identified stages in the evolution of STS, but I think almost anytime you have a big complex problem, breaking it down into some kind of component parts makes it a little bit easier to tackle. Some of this material may be covered in Patricia's work, Patricia Carrick's work, and I also want to highly recommend that supervisors become familiar with that work. But I think beginning someplace, making a commitment to beginning to have conversations with people is probably the place to start. Um, and I don't know if that's on point here or not, but that's what occurs to me. Do you want to add anything to that, Julie?
As I said, and I'm not sure I totally followed the question. If it's translated in a way that my simple mind can digest it, I'd be happy to add. Anthony?
Well, I think that I mean I think some of Terry's points at the beginning of about where we are in terms of particular stages of STS might get at some of the core of the question here. The person you are feel free to ask an additional or elaborate further in the Q&A box if this doesn't address what you had in mind. Somebody else asked if certain cases do prove overwhelming or triggering to a trainee and that doesn't seem to be lessening in time. How do you go into considering how that's affecting their competence or their training and completion of the program?
I mean, I think it requires some candor and some checking in. Usually, trainees are aware of that, and I think part of trauma-informed principles is really about transparency and fostering trust and sort of being open and getting their perspective as well about goodness of fit and what is going on for them within the confines of a supervisor's role. Terry, do you have more to add?
I'll just add this, that I've tried one of my favorite things about being a professional psychologist of my vintage is that I've been able to do so many different things professionally. And I found some of them I really enjoyed, and a lot of them I really did not enjoy. And I think learning that about myself, about what was going to be satisfying and fulfilling professionally, maybe if that's an outcome to somebody not improving, what a good thing to have identified at this stage in a career rather than mid-career or even late career, that this may just not be for you.
The person that asked about the secondary trauma stages did elaborate and say they were referring to typical stages like chaos, intrusive reflections, restoring personal integrity. If there were any particular stages like that that you felt were particularly relevant in these kinds of cases. Um,
We generally, and again, I defer to Patricia. We generally focused on how sort of Harrison Follett's sort of five principles might map on in a more general way in our paper. So we actually did not address that, and I don't have much to add on that topic, but it does sound interesting. Terry?
I wish I knew more about that.
okay. All right. Well, thank you so much, Julia Terry, for your thoughts, your recent contributions here to this issue. Many people sending some additional comments in the Q&A box from professional and personal reasons, thanking you for having these kinds of conversations, and we very much appreciate your perspective. Whether people here are a trainee supervisor or whether they are a supervisee, it is much appreciated. So thank you for your thoughts and contributions in this matter.
Thank you for having us.
Yep, thank you.
Absolutely. That does wrap up this week's Law and Mental Health series. Next week, we do have Dr. Ira Packer, who will be discussing assessing need for hospitalization among incompetency examinations. So we hope to see you next week then for another great discussion of issues in behavioral health and the law. And until next time, take care.